Perfect. As we've previously mentioned, we will focus on the restrictive practice process for this session and touch on the monthly care statement towards the end. So essentially, and what we have to remember too is the documents that we do have in MANAD are not something that we've put in there to make your life harder or to make your work harder or document harder. These are in line with compliance and with with quality indicators and everything that goes along with it. So essentially there always is a bit of, I guess, some clients that I deal with are quite unsure on what is the process, which is the best way to approach it. Now, you guys may be fine and know it, but I'll just take you through what the process is, not just from the MANAD perspective, but also from the compliance perspective and the standards perspective. So essentially on screen here, I've got a sort of just a stepped out, very basic here. So essentially what we want to do is obviously start with the behaviour charting to identify any behaviours. What I guess too is that some clients tend to forget when they're doing their restrictive practice process is the importance of the risk scales. So things like your confusion assessments, do delirium, all of those that go along with it. What's important is that your FRATs, your Braden, anything that can substantiate or provide evidence to this process that you're about to embark on. So it's our risk scales. Once we have our behaviour and risk scales going completed, then we want to move in and we start with our behaviour assessment and build that care plan. If behaviours of concern have been identified, we're then going to move into getting authorisation. So our restrictive practice authorisation comes into play here. We have that. We then need to proceed with the restrictive practice assessment and care plan. What restrictive practice is required here, or is there multiple? And finally, as per the requirements, as per your legal obligations here, is that we must have a behaviour support plan. Okay, does that make sense? I guess too, what's important to note here is that all of this is going to take place when we've exhausted all the possible alternative strategies that could combat this or possibly even prevent this from progressing to the use of restrictive practice as per the guidelines. Again, what's important to note here, just before, not a disclaimer, but just something to note that, while MANAD does provide the tools and resources, it's essential that the organisation applies that within their own governance, frameworks, policies, and care practice to demonstrate that full compliance. So essentially here, we provide the tools. Unfortunately, we haven't got the resources to do it, and we don't know the people that you're looking after. Okay, any questions with that? Everything okay? Beautiful. I'll move on. So where I am in here, I'll just sort of close all this off. Okay, and I'm just going to collapse this for the moment. What I've done here, I've just sort of prepped a client called Jim Fletcher. I'm not going to go to the ins and outs of it, but I guess what I get asked most, and the same with my colleague Mark, is what are these documents actually asking? What do we put in here? Would you agree with that? Like, what does setting events mean? What do they want? What are these questions, and what do we need to put in them, and where? So we'll have a look at our first one, our starting place here, which is going to be our behaviour assessment. So I'm just going to bring one up. And I have completed all of this, so I won't go through the tin tags. But what we want to really look at is the questions and what they're asking. So I'll just go into my Mabuli one here. Okay, we've got our, displays behaviours of concerns. And what are we looking at here with our setting events? And again, these are as per the standards and the indicators. So we're looking at here understanding the person's environment and context to provide appropriate individualised care that respects their dignity and promotes wellbeing. This is what we have to focus on, the setting events, the environmental, social, situational circumstances when behaviours occur. So, for a couple of examples here, for the physical environment, the location, the noise levels, lighting, temperature, crowding, and the social context. Who is present? Are there visitor situations that could be causing the behaviour? So what is this event like? We also need to have a look at timing factors, which is really important. I had a client recently that was that had a visit, and they were a bit light on the frequency of these behaviour or any depth to the frequency of these behaviours and their specific timing. And of course, the behaviour description, the objective and observable actions without interruption, what you hear, actual words spoken, tone of voice, volume, body language, the resident's posture, gestures, eye contact, movement patterns, and the duration, how long the behaviour lasts from start to finish. Is there any questions with that? Is that all okay? Dodie, any questions?
No, that makes sense with me, but feel free to ask questions if you go along.
Absolutely,
or
feel free.
At the end, we can have time for questions if anyone's got any questions, just as an opportunity for everyone to be able to talk freely, why there's a group and network a little bit about some questions you might have.
Exactly. And again, just moving into our frequency area here for our 4.3, what are we asking, or what, not so much manner, but what is this question? What depth do you need to go to here? So it requires the accurate data collection to inform care planning and risk management decisions. How often the behaviour occurs? Are there daily patterns? So if it's daily patterns, is it 3 to 4 times daily? Is it every morning? Is it twice weekly? What's going on? What are the specific timings? Is it situational frequency each time unfamiliar staff are provided? Trend information increasing from once weekly to daily over the past month. How long each episode lasts? Is it 5 to 10 minutes? Is it during meal times? Is it for the full 45 minutes over a meal time? And obviously the onset to resolution begins immediately when approached, resolves within 2 minutes of staff withdrawal. It needs to be quite specific here. And why this matters, why are we getting this in here? So it's, the risk assessment for frequent prolonged behaviours may indicate unmet needs, resource planning, staff allocation and time management, treatment evaluation, measuring if interventions are reducing with frequency and duration, regulatory compliance, evidence-based care planning requirements. So this is where all this data, and I know as we move through the other restrictive practice documents, it does seem a lot of repetition, but again, this is coming from the standards. So we need to be very clear with this documentation. Moving down here with our strategies and options that were discussed with me, my representative for the management of behaviours I display. What was the conversation here? So all of the different approaches, techniques or interventions that were talked about with the person and or their family representative before deciding on a care approach. So I can't just, I guess, and you may already, be aware, and I'm sure you are, that we can't just say, okay, this is what we need to do. It has to be collaboration. And I have had clients that have gone through this and they have looked for that collaboration and evidence of that. So we have that collaboration planning process. Who is involved? So the resident or the consumer, the family, the GP, allied health professionals, any care staff. When did these discussions occur? Was it formalised, family conferences, care reviews, Teams meetings? How did it occur? Ranges of approaches discussed, the pros and cons of each, and decision-making process, how final strategies were chosen, and if possible, the resident input, the person's views, concerns and preferences expressed. Of course, this needs all to be evidence-based with professional recommendations from their healthcare team, best practice guidelines to standards and relevant protocols, and any previous experience, what has worked, what hasn't worked. This one here, my positive behaviour support strategies. Again, I find that I get a lot of questions on this. What are we actually looking for? What needs to go here? It really needs to be strengths-based, identifying and showing evidence of dignity-preserving approaches that promote the person's autonomy, choice and wellbeing whilst maintaining safety. Proactive strategies, what staff would do to prevent or minimise behaviours after consultation here. Environmental modifications, noise, reducing noise, lighting, creating calm spaces, communication approaches, what words, tone, pace, and non-verbal techniques are being put in place here. Preparation techniques, choice and control ways to maintain the person's autonomy and decision-making. Responsive strategies, how to respond when behaviours occur. And what's important also here are de-escalation techniques, diversion strategies, comfort measures, and safety protocols. Okay. So it is quite a comprehensive approach, isn't it? Okay, have we got any questions with that? No? How are you finding it? How are you finding this restrictive practice process? It's probably where we should have started. Speak up. I don't bite. Do we find it overwhelming?
I think that the questions have been about the new Substitute Decision Making Act with Victoria and the Tier 1, Tier 2, Tier 3, Tier 4. Yep. We had a presentation from the Victorian Department of Health Policy 2 weeks ago, and they were very good in their explanation presentation. They spent time. So I'm just here, it'll be really beneficial to be able to put who is the substitute decision maker if they're Tier 1, Tier 2, Tier 3. And I know you're doing that in your next upgrade, yes. Is that right?
That's right, yep. So that is coming, definitely.
Yeah.
And you'll probably, in behaviour assessment, you'll be able to make reference to it. It'll be free texting in that.
So, and I think that's the important thing for everyone to know. The only substitute decision maker requirement is for a mandatory form is for Tier 1, and that's for anyone who arranges it generally before admission. The rest is there is no mandatory government form that has to be completed. They will have to be documented as Tier 2, 3 or 4, and well, it's not for Tier 2, Tier 3 and 4. If you get a VCAT, it will be documented on a VCAT form, but they will need to be documented in your progress notes and
the authorization, restrictive practice authorization. Yeah, that's
you
right.
have had yes, and I think what you were saying about the positive, what do they call here? Positive behaviours.
Yeah, my positive behaviour strategies. Yeah,
they're really important to focus on too. What really works well to, and we've just had a question in the chat. From Lisbeth saying, I was late to start, and you might have said this already, but where do I find the behaviour assessment?
Oh, okay, sure. I'll take you back to that. Absolutely. So I'll close out of here. Your behaviour assessment is in care documents. To complete one or to start a new one, you're just coming up to add new. Document type is assessment. The category is activities of daily living. And what you'll find there is just that first one where you see behaviour. So when I select that behaviour, that's going to open up a whole new behaviour assessment for you. So essentially, I've sort of started one here. I'd select that behaviour, click start, although it's going to give me a prompt here. Let me grab another resonant. Hit start, then that will bring up my behaviour assessment. Everyone okay with that?
Yep. Yeah.
Beautiful. Okay. So we've done our behaviour assessment. We've identified at this point now that the resident does require a restraint of some sort, or restrictive practice, I should say. Where to next? What we have to do then is get this restrictive practice authorisation completed. So in we go to here. And I've again to find this document, if you're not familiar, where that sits is if I come up to add new. I'm just going to grab another resident. Where you'll find that is under our authorizations category. So I'll select authorizations, and you'll see under there that you've got your restrictive practice authorisation. So this is going to be really the first stepping stone once you've identified that restrictive practice is in place, is all required. Okay, so into the restrictive practice authorisation, I'll edit that. Okay, coming back to the new authorisation structure, there will be a change to what you can see here under this informed consent area, and it will be based on those new requirements, FIC requirements. So you will have your tier 1, tier 2, etc. underneath there. Everyone all right with that? So it hasn't been done as yet, hasn't been released, but it is coming. So you'll be able to document that. Okay, so informed consent details, what are we putting in here? I have done reviews before, and often this is left blank. In the authorisations, yours could be completely different, I don't know. But really, what is this, the informed consent? What is the purpose of this? It's to ensure that the resident or their legally appointed substitute decision maker is fully informed and provides valid consent before any restrictive practice is applied. This is our reasoning behind all of this. So we're looking at standard 1, the person. It's a legal requirement, and obviously we can't have restrictive practice unless informed consent has been provided and provides transparency and safeguards resident autonomy within here. So it is important to sort of provide a little bit of background in that area there. Okay. Do you have any specific questions here within the authorisation? I guess to another one where I find there is some gaps across completion of the authorisation is in this area, even the role in this section. So once we've got consent for use of, I've got chemical restraint in this scenario, where this has come from. So we've got our GP, it could be multiple, could be a whole healthcare team. And what's the purpose of what are we putting in the roles? We need to identify that to confirm that consent from the treating medical or nurse practitioner or our other allied health who has day-to-day knowledge of the resident, and that you've provided them with the information to provide you with the authorisation. Okay, again, this is required under quality of care principles around decision and clinical justified, least restrictive and evidence-based. It also supports standard 2, the organisation, and standard 5, clinical care, ensuring safe and accountable practice. Any questions for that? How do you find that? Do you find that these are sometimes sort of left blank and you've got to go back and have a look at them? Yep. Okay. Is this making it a little clearer what we're after? Yeah.
Well, I was just wondering with the role, I don't know if I'm going off track a little bit, but will they have some of the wording from the Substitute Decision Making Act because that's a role of the person who said it needs to be, not the role of the person who's consented, isn't it? So that's right. A role. Yes.
That's right. It's where we're getting this authorisation from.
So we'll have to say that they have an understanding of the person's needs and care plans.
Exactly. Yep. That's exactly right. Okay.
Jackie.
And of course, yeah.
Sorry, it's just Donna. Sorry being a little bit late.
That's okay.
So before we even get to this point, that's when we have to fill in the form and have it witnessed of actually who the substitute decision maker is. Like that's where we've got to get a justice of the peace or someone before we even get to this.
Only for tier 1. Donna, for tier 2, you only have to have that person nominated and documented that they are the substitute decision maker. So then you could put substitute. So anyone basically who's in did you come to the substitute decision maker presentation from the Department of Health a couple of weeks ago?
No, I was off.
Yeah, watch the recording. It's been sent out now and it's really quite helpful.
Okay.
I'll send it to you, Donna, if you haven't got it.
Yeah, that'd be great.
So tier 1 needs to be a mandatory form from the Victorian government needs to be completed and signed by an FD. It's signed by Justice. Tier 2, if you're using the hierarchy and that person hasn't decided and can't decide, that just needs to then use the hierarchy. And so basically anyone who's in your facility now and who's already nominated their person, that can carry on.
That can carry on. Okay.
As they can be documented as a tier 2 substitute decision maker. Conversation is had. That's a person that wants to. They don't necessarily have to do a tier 1.
Yeah, but do we have to get that every time when we're going to give a restrictive practice? Like if it was chemical,
you have to get a consent every time. You have to get consent. You have to have it documented. Someone who is the tier 2.
Okay. Yep. No, thank you. Sorry.
It's okay. What you could also potentially do is you could also, note the attachments tab at the very top there. You could always attach that document, that signed document into the restrictive practice authorisation here, just so you've got that additional evidence in there that you've got it. I think also too, having it in here is great because it's sort of like having all the information together in one place. What it also helps with is that if you do have a visit, you don't have to start, oh God, where is it? Where was it filed? Where was it put? Attach it, scan it in. So then you can have that level of confidence that when you're in and they're looking at your authorisations, which I'm sure they will, they'll be able to see that attached signed document. Just something to consider there as part of your process.
Hi, Jackie. I got a question.
Yeah.
Are we attaching the signed BSP or we attaching the antipsychotic form authorization signed by the family here?
Well, you can attach whatever you want. You can have multiple attachments in here. What I was more sort of directing this at here is, and again, you can have as many attached supporting documents as you like. If you've got that initial signed by the JP, did you say, Dodie? Is it?
Yeah, tier 1 is signed by
tier 1. If you want to attach that document to this authorisation as supporting evidence, and you've got that because they may ask for that, you could attach that document as well into this attachment area.
I guess, Annie, to answer your question, it would depend on your process, your health service process. And I think Amy said you've got a clear process. Yes, Amy's hands up. Yeah. Go, Amy. You can answer that question for Annie.
So we're looking, once the restrictive practice authorisation form, the one you're looking at now, Jackie, is updated to the tier stuff, we will start utilising that at Bendigo Health. Currently, we're utilising the behaviour support plan and recording in section 1.2.12, the conversation around that temporary decision maker, because majority of our residents will be temporary decision maker tier 2. So we're recording that conversation under that section. And we've just finalised what we're doing for new admissions, because you have to have that conversation prior to them coming in, especially for places like Annie's facility, which is Simpkin House. So as soon as they walk in the door, they're environmentally restrained. So we have to have that authorisation prior. It becomes a reportable incident.
Yep.
So we're just looked at when potential admissions coming in, they're added to the wait list on Manad. And we're going to document that conversation under the communication tab in the waiting list. So we'll put it in there that the conversation was held on this date, go through the hierarchy, whoever it might be. Tier 2 was identified as the son, who's the primary carer. Conversation held, is willing and able, all of that required documentation for the legislation. And then once they are in the facility, we can put that in as a late progress note, just so it's available there as well. And then we can attach it via the communication tab in this restrictive practice authorisation.
Perfect.
And that's as well great. On the behaviour support plan as needed. So that's where we're kind of going.
Great. That's really comprehensive. Fantastic. What you may also do, I'll just minimise this for the moment. And something to consider also when I come into admin and into clients, when you can set up your contacts here? What you could potentially do here is, so I've just gone into admin, selected my client, into the contacts tab. I'll just edit this and click edit. What you could potentially do here, where we've got our types, this is a customizable field in here of the types of contacts. So if you want to be really clear here, you could set up your tier 1, tier 2, etc.
That's
in
what
there.
we're looking at doing too. Yep.
Yeah.
Okay, excellent. Yep. That's great.
And then so when staff go to the contact list, they can clearly see that they're the tier 2 person, and then we can modify and change it if that changes in the future, if they're not willing and able. Yeah.
Yeah, that's exactly right. And of course, that will also assist with reports. So if you've got it set out like that, you'll be able to bring up a contacts report and group it by your tier 1, your tier 2, whatever it is, to make it a lot clearer and readily and accessible very quickly, which will indicate that you're across it.
Danielle has a question for you too, Jackie.
Yeah.
Hi, Jackie. Hi, Jodie. So with that authorisation, we're not using that currently. We've made up our own form some time ago when all this was happening. So I haven't seen the end of it, but you can actually, there's a place for the person, the restricted practice substitute decision maker to sign the authorisation?
Yep, that's exactly right.
Yes.
Yeah, in hard copy.
In hard copy. So if I close that, and what we are looking at, obviously it's not going to be done overnight, but eventually when we're moving across to the web app, we are looking at digital signatures as well. So that is in development.
Oh, fantastic.
Won't be overnight, so don't hold your breath, but it is on the roadmap. It is on the roadmap.
So once it's signed, sorry, do you sign like you?
Yep. So let's just say it was completed.
Yes. Yep.
I'll look at this one for the moment. What you would then do is, or even in the to be approved stage, whichever, like if stage you've got, you'd come up, highlight the document, come up to print document. I'll just do print preview for the moment. So this is my completed document here. And you'll note at the very bottom, you've got your authorisations.
Right. Yep. Okay. So you could scan that and put that back in and as an attachment as well. Yeah.
Yep. Absolutely.
Yep. Okay.
And that would be my recommendation, to have it all in the one place. What you want is to feel confident that for your own records and your governance, to be confident with that. But also if you do have a visit, it's all there. So you don't have to think, oh God, please be there, please be there. And again, what you can also do on screen, so it's, you could basically set up a restrictive practice view like I have, where you've got all of your behaviour assessments, all the documentation that's required here. And what you could even consider adding to this would be, so if I just do a right click on the screen, go to my column chooser, you could potentially look at, adding things in. So let's have a look at, let me have a look what I'd probably look at to think about it. Bringing in your attachments. So I'm just going to bring attachments count in and add that to the screen. So what that would then allow me to see and make that part of my view, attachments count's going to show here a figure, whether it be 1, 2, 3, depending on how many attachments you've scanned back into this document. When I've got that, as I said, it'll come up with a little value there. When I click on that, it'll automatically take me into that attachments tab and show me the documents that have been attached here. So whilst it's great to have that on screen, it's also a really good audit to see, okay, this one hasn't had it scanned and put back in. Where is it? Does that make sense? Perfect. Okay. Any questions with that? No? Let's jump back into this, the authorisation.
You were on mute, Jodie.
Sorry, just a couple of things, Jackie.
Yeah.
I've just attached the YouTube to the chat, but I've also sent it out to the key representatives if you haven't received the link to the video of the presentation from the Department of Health. And there was another question before, Jackie. It was something about, someone had put in a question about.
That was Marie. Sorry, was that the question about allied health?
Yes.
So I said, can we please clarify, it's Marie, can I please clarify what the expectations for allied health completing in the MANAD report? Because you're talking about all the sections. Often we would go in and complete a file note from allied health, but I'm just not sure where we fit in the scheme of all of this. Have I made sense with that statement, that question?
Yes, no, you have. Where that would go, that would be part of that collaboration of like, was there a family meeting, a clinical meeting, a case conference? Who was involved in that? And what were the discussions from each of those team members?
It'd probably be more related to, if in my thinking, tell me if I'm wrong, anyone else, maybe like bed poles or a lowered bed.
That's
or
what
some
I'm
sort
wondering about.
Yeah, so if your allied health is involved in an assessment where it assesses that there is a need for, bed poles or the bed to be lowered, or for a safety reason that's needed.
Or dignity of risk,
letting them. But it's still considered a restraint, even though there is the choice. That would just probably be the recommendations of the allied health would be relevant to be attached to the
absolutely
assessment.
Yep. As I said, it's the collaboration. It was who was involved in the discussion and the decision around this.
Okay, so in the communication or the care, sorry, so when you say collaboration, where am I looking on your screen at the moment? So when I look at the MANAD report, it's got care documents, actions and communication. Is it up here in this restrictive practices? Where am I writing the note?
So sorry, Murray, because you work for Glanville, can I just?
Sorry, Danielle, go for it.
Yeah, no, we would just expect, if you're doing, say, like an OT assessment for bed poles, for example, we'd expect you to do your assessment. Then we could save that in the attachments in here. So we wouldn't expect you to do anything in this document necessarily. We would probably a good progress note that we could copy and paste into it. We would just use your assessment and copy and paste into the document itself. Is my understanding. I think.
Thanks, Danielle.
Yeah,
that's what we were doing. I didn't know whether that was changed given the new Aged Care Act. Okay.
No.
Lovely. Thank you. I'm sorry, I'll have to go. Sorry to interrupt. Thank you.
That's okay. That's all right. We'll just move on. So with your emergency use, do you have any questions around here, around what we're documenting and what we're looking at in this area with the emergency use? Is everyone clear and okay with all of that? So we're really wanting to outline clearly the conditions for the use of the restrictive practice in situations. We're meeting the legal requirements. We're supporting Standard 5 and, of course, Standard 1 across here. So everyone's all right with that? No questions? Any additional details? Again, I often find this blank, but this is your opportunity to, provide anything that hasn't been addressed anywhere else in the document. If you feel that, you want to sort of break out and away from those specific questions, by all means, provide that additional information in here. Okay. So that's our chemical restraint. Our authorisation. What else here? We're looking at our chemical restraint assessment. How's everyone going with these, with the actual assessment and care plan? It's a lot of work, and it does feel like a lot of repetition across the suite of those documents. I'm not going to deny that. However, there is importance there. Any questions?
Yeah, sorry, just Amy from Bendigo. We currently don't utilise this assessment. We utilise the behaviour support plan because that's what's required. And it has pretty much the same questions in it.
Does.
The only other thing that's kind of it's not specifically called a fade out plan, but there is
Yes.
definitely sections in the behaviour support plan where you can put in your plan for deprescribing chemical restraints, those sorts of things. So we don't utilise this at Bendigo. We utilise the behaviour support plan, and we have other behaviours in regards to problems and risks around mobility. That's in the mobility care plan and assessment.
Okay.
Sorry, Jackie, have you considered putting the fade out plan in the restrictive practice? I mean, in behaviour support plan, because it's double work.
It is. I know. No, but I can take it as feedback.
Yeah, because the Act and the strength and standards only say you need a behaviour support plan or care plan, not that you need both.
I know. I know. I think there has. So you could potentially, again, this would be an internal decision and go down the lines of what Amy and her team have done, and you could hide off the actual restricted practice assessment and just move straight into the behaviour support plan, because it is a lot of repetitive information here.
Yeah, it would be great if it was all in one to reduce that workload. Danielle, what do you do?
So similar. So we were doing the restricted both, all of it, and we only do the behaviour support plan now.
Yeah, that's what Bendigo did. We started doing both, and it was too
much.
And then there'd be things missing, not completing one and completing it, putting yourself at risk of
and also incongruence, I guess.
Inconsistencies, yeah.
Just with the authorisation, sorry, Jackie, and with this, so if we were using this, we do a separate one for each restrictive practice? So I see the other author, so you can't put them all into one, because I see the authorisation has, you can also do environmental. You can't, you recommend doing a separate one for each restrictive practice?
Yes.
Yep.
I would.
Okay.
And I think that is, and quote, also correct me if I'm wrong, I think there is the legal side of it as well, where you would need consent and authorisation for each individual restrictive practice type.
Oh, yeah, of course. Yep. Okay. Thank you.
That's okay. Righto, so that's that. And our last piece of the puzzle here is this behaviour support plan. Any questions with that? Are you bringing through your client profile form, your leisure and lifestyle, and are you attaching, like we discussed at the very start there, all of the relevant assessments here that are evidencing this behaviour support plan and the requirements around it? Yep, are they all coming through? Perfect. Any questions at all around this? Is there anything tricky that perhaps I can help you with, or is it all coming together okay? Any questions? Hands up. No?
I can't see any coming through.
Perfect. All right. So that's covering that. Before we move out of here, we've covered the process. We've covered the restricted practice documents. Again, do have up to you, but do consider setting up a view, so then you can actually access all of that information very quickly and scaling it down.
Jackie, is there any chance that you could send through how to do that?
Yeah, sure. I can demonstrate.
If people don't know how to do it.
Yeah, sure. So I can demonstrate now as well.
I know, like Amy and some of the people that I know would know how to do it, but not everyone might not be able to do it.
That's all right. And I can demonstrate, so then it is on the recording here. So I just have my location, and I can, just choose my date range here. I'll just go all for the moment. And if I'm just wanting to focus down or, isolate this down just to specific documents, in this case, the restrictive practice, I'll just click on that little document filter. I'm going to remove all and now just start to select the documents I want on screen. So I've removed all. I'm going to select behaviour, assessment, behaviour support plan. I'm going to scroll down now to my restrictive practice documents here. Select those. When I'm happy with that, I'll click OK. Everyone right? And what I can do then is group this by document. And then it's going to break it down for me, all of my behaviour assessments, my support plans. You won't have the restraint if you're not using them, the assessment, the authorisation and the type of authorisation. So you may have multiple there. The other thing that we did look at before, something to consider, is adding into that, whilst we've got all those lovely documents on screen, is do we want to know, have documents that you've discussed and you've made your internal policy or governance about scanning and putting them back into those documents. Let's make it easier for you. So we'll just do a right click on the column header. Go to the column chooser, and we want to choose that column that's going to provide us with that information. And it's going to be attachments count. So I'm going to grab hold of that. I've got hold of it with my mouse, and I'm just going to bring it in and create a heading with that to provide me with that information. I'll let it go. So what I can see now, it's added that into my screen here, into my grid. Again, you might want to hide off columns or all that, but at the moment, what I would suggest is getting it something similar to this. When you're happy with that, you would come up to your views button here, create new view, and give it a name. From here, you may not want to set this as your default view because you're going to be looking at lots of other things here. You may not want to set it as everybody's default view because that would cause so much confusion. What you would want to do here is have it a view as available to everybody. So then anyone that needs to access information will be able to see that view available. So go for that middle option there, click OK. What that means for me now is at any time, if I'm doing a weekly review on this or monthly review, I'll close out. When I come into care documents, we're back where we were. I want to go back to that view because I want to do a quick audit on all of this and see where it's at. I'm going to come across to my right-hand side. We did start there. I'm going to go to that little drop down, click on that arrow, and let's bring up that view. So you will have a list. I'll click on that view. It's then going to provide and display that information that I've selected. So you don't have to go through that clicking and grouping every time. Everyone right with that? And you only need to set this up once, and as new care documents are added into the system, they'll get applied to this view that you've set up. Beautiful. Okay, we'll move on to our monthly care statement. Are these being used? Have they started being used? Yep. Bendigo, yes, perfect. Okay. So I'll just do a little overview here. So heads into our client summary, print document, monthly care statement. Just to give you a bit of an overview where all this info is coming from. All right. So with our monthly care statement here, leisure and lifestyle participation is coming from the lifestyle activities area. Now, if you're finding at the moment that some of your care statements are becoming like ridiculously long because you have residents over a month that participate in quite a number of activities, we are looking at, and I've just signed that off, is a redisplay of this. So basically what it'll do now is just a count of each of those activities rather than each individual activity. Are you smiling, Amy? Are you happy with that? Yes, because they were getting lengthy. Yep. And it will be displayed as a count and a percentage as well of how many times they've applied that. Client incidents coming from the client incident form, though you guys don't do client incidents within MANAD, do you? You do? No, some do, some don't. That's all right. I can speak to that shortly.
Bendigo Health does, and the rest of the region don't. They use HIMSS.
Yeah. Okay. I can speak to that in a moment. Wound, coming from your wound area here. Hospital visits, so any of the hospital leave, admissions and back in are coming from the admin area. Appointments are coming from the organiser, so you may want to start to look at putting in those appointments in the organiser, so they'll populate across into here. As you can see those, I've got a couple in there. Your current weight is coming from the weight monitoring chart. Diet, any of this information here is coming from your nutrition hydration assessment. Allergies, medication allergies from the medication assessment, food allergies from the nutrition assessment, general allergies from lifestyle. Mobility coming from the mobility assessment. Vaccinations, if you're using it, will be automatically populated for that month from the vaccination area. If you're not familiar, and this is very poorly put together, but if you're not familiar with it, in our last version, we introduced the monthly care statement event type. That is a locked event type from the progress note area. The reason we have this is for a number of reasons, because in recent months they have been pushing out the need for additional information or a summary of the information that's appearing on the monthly care statement. So basically what we did, and also just a bit further to that, is we have a number of clients and you all have different medication management systems. So we can't interface with fully interface with everyone that's going to pull across the reasons for any medication changes over a month. So to sort of combat that, what we've done, and also to allow you to provide additional information, is we've created in the last version, I'll just close out of here and I'll jump into progress notes. Just add new. Okay, so within our event type here, we have a locked item known as the monthly care statement. Anything that goes into this locked item here is what's going to populate across to that additional information area on the monthly care statement. So that's where that's coming from. Now you can just free text in, or what you could do, completely up to you and your process here, is you may even consider doing a macro for this based on the sections or questions within the monthly care statement. So what this then would allow you to do is to do a little bit more of, or give you a bit more possibility of a narrative as to what's going on under each area, like a bit of a review, I guess. So client incidents, while some of you may not be using client incidents within MANAD, you could just do a brief review, 3 falls over the last month related to blah, 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 and what were your strategies put in place? Because you don't want to have to, obviously, and again, internal decision is document in 2 places. The other area here, which you would certainly want on your care statement, are any of the medication changes. So you're not providing with a separate document. It's not going to pull out from your medication management system, but here will allow you to put any those additional information and narrative around what those medication changes were and the reasons why. Okay. Any questions? All good? Perfect.
That's all good. There was a question that I missed before, sorry.
Yeah.
And it's from Mel Church, and it says, forgive me for my lack of MANAD knowledge, but in all the boxes in this display, and I'm assuming it was when we were on the restrictive behaviour support plan, was it Mel? Are there many hints on what to document? Are these included in the live versions, or can they be to assist staff with what they should consider when documenting? Mel Church, are you still on?
Yes, I can see Mel.
I am, yes. Yeah.
Sorry, I missed that.
No, that's okay. That's okay. I don't obviously use MANAD, so I'm lost. But I just wonder, when you're documenting what,
Yep.
like in your boxes, in your example, are they in the boxes in the live version? I'm just thinking, you know, it's always when you're saying that the boxes are often left blank, is that because they don't know what to write?
Often the
You know,
case from
yeah.
feedback that I get. It is often the case. We don't. These are just, I just pop those in there.
Yeah.
Again, what I could do here is, if you want me to, when I can send back in an email to those that attended, I could do a preview, because this again isn't a real resident, so I'm not you know, breaking any rules here. I could potentially just send you like this, so you've got a hard copy of it. Would that work?
Yeah, yeah. I don't know if anyone else has the same problem. You know, not problem really. I guess it's just lack of familiarity with what they're documenting in there.
It's always nice to have an example for people to have a guide.
Yeah.
It's like a template guide. It's people like that. I like that.
Yeah, I like that. That'd be good. Thank you.
Yeah, I'll send this back to you. Again, I'm not breaching any confidentiality, because this is a made up person. And this will just point format down what those questions are asking for. And I do
Jackie,
find
everyone thinks that will be great. There's lots of good positive comments in the
perfect.
comments.
Because to do this yourself takes a long time. And yeah, it does end up with a bit of a headache in the end. But yeah, absolutely, I can send these back to you. I'll send back for all of the ones that I've done here.
That'd be fantastic. I think that would
Okay.
be well received. Sorry.
Beautiful. Any questions? What do you want? A few minutes back in your life.
Has anyone got any questions about the monthly care statement? I sort of went off track a little bit. I'm sorry.
That's all right. No?
Oh, sorry, Mel's got one.
Sorry.
Mel?
Yep.
Me again. Sorry. I'm wondering if anyone has had any difficulty with how they're posting. Are you posting? Are you emailing? Do you find I find it difficult at the moment to have the family member or the next of kin or whoever wants to get the monthly care statement to even have an email registered in Manad? Any tips, any ideas? Do you post them? Do you email them? What are you doing?
I think people are using a combination, but I'll see what someone's saying something. Email, I think in the notes, someone's saying email. Pleased to see the monthly care statements, and we'll be reviewing them, implementing them. The monthly care statements, I have to say, Jackie, they're good. I mean, they have what you need. They're not perfect, like nothing's perfect.
No.
But they work. Danielle's got a question.
Yeah. Sorry, Jackie, just in relation to the terminology that's changing, you know, supporter, individual, all that sort of thing within the new Act. Is Manad making changes to that? Because I'm seeing a lot of documentations coming through from everywhere, and they've still got consumer, care recipient, older person, even the stuff coming from the Commission, and the Act itself has older person and individual. I was just wondering, what's everyone doing, and what's Manad doing in relation to all of that, and will it start on the 1st of November or
I spoke to Jackie about this, and we're still going to say client list, I think is what but when in the care plan and everything, it actually refers to the older person by their name. Like it never says resident or consumer. Yes. So it always refers to the older person, the individual by their name, but lists and things will still say client list. Is that right, man? Jackie, am I?
That's right. Yep, that's right. The reason for that is because the Manad application is also used by retirement villages, ILU, home care, the whole kit and caboodle.
Childcare as well. So I just
home care, not childcare. Okay. God, don't bring that into the mix.
No, that sounds scary at the moment. I wouldn't want to be there.
No, I know. I wouldn't touch it. So, and client has always been the same. Even when they introduced consumer, you know, we didn't change our terminology from client to consumer. We had hundreds of people go through accreditation and it was never picked up. Where it's going to be is again, through your documentation, is referring to that person, to the person, to the older
Make-
person with their name.
Yeah.
Change the policy to older person or individual.
Or individual name.
Yeah.
Yeah. Yeah.
Don't get rid of consumer, resident, all of those.
In policies. Is that what everyone
Yes.
else is doing? Yeah.
Yeah, that's
Okay.
what I would highly recommend, Danielle. I mean, as far as anything you're sending out to the older person or the individual, if it's their choice to continue to be called a resident, use those terminologies because that's their choice. But when they're policies or guidelines to the staff, use the words older person or individual, supporter of the individual. Use the words in the Act now.
Yeah.
Yeah.
Okay.
Remember
Yeah,
that
great.
list of terminology that I sent out a couple of weeks ago? I would
Yes.
use those. Yeah.
Yeah.
Right.
Okay. Thanks.
I think Michelle was saying that they discussed resident executive morning tea and residents want to remain residents, not consumer. So
There you go.
as have those individual conversations with the residents and make sure that they're informed and it's not just a conversation. Do you want to explain what that means as far as person-centered care, that residents and clients are labels? So if you prefer to be called by your name or older people as it's not really a label because you are an old person, even though I know that some residents don't like to be called older people. Just make sure it's what they're informed about the choices and what that means.
Mm.
And maybe even give them the list of terminologies for them to make that informed choice themselves. Whatever way works for you. Has anyone got any questions for Jackie? I'm going to give everyone 4 minutes back in their time because I'm
Flat out.
gonna know.
Beautiful.
Sorry, just any idea on time frame, Jackie, for the restrictive authorisation to be updated?
Good question.
I'm assuming it'll probably be, will definitely be before November 1, but hopefully it'll be in the next version, which I think is end of September. I'm not 100% sure, Amy, but it certainly is. It is with the development team. Beautiful. All right, team. Thanks very much.
Thank you very much, everyone.
You're welcome. Bye.
Thanks. Bye.
Thanks, Jackie.
You're welcome. Bye.
Thank you. Bye.